Presented by Dr. Mohammed Rashid. Acute pericarditis. Presented by Dr. Mohammed Rashid. The pericardium, a fibroelastic sac composed of visceral and parietal layers. It normally functions to protect the heart and reduce friction between the heart and surrounding organs. Both these layers are separated by a pericardial cavity. The cavity normally contains 15 to 50 milliliters of straw-colored fluid. Visceral layer is in contact with the epicardium, saint elevation. Diseases of the pericardium. Acute and recurrent pericarditis, pericardial effusion, cardiac tamponade, constrictive pericarditis, acute pericarditis, inflammation of the pericardial sac. The term perimyocarditis is used for cases of acute pericarditis that also demonstrate myocardial inflammation. It may be accompanied by pericardial effusion, which is fluid accumulation in the pericardial sac. Can be an isolated entity or part of a systemic disease. 0.1% of all hospitalized patients. 5% of ER visits for chest pain without ANMI. Causes of pericardial disease. Which of the following choices is the most common cause of acute pericarditis? Neoplasm, uremia, viral/idiopathic etiology, radiation exposure, complication of myocardial infarction. Which of the following choices is the most common cause of acute pericarditis? Neoplasm, uremia, viral/idiopathic etiology, radiation exposure, complication of myocardial infarction. Diagnostic clues. History. Sudden onset of anterior chest pain that is pleuritic and substernal. Physical exam. Pericardial friction rub. ECG. Most important laboratory clue. Echo. Showed free area between pericardium and wall of L ventricle, not useful in early stage of dry pericarditis. Presence of at least two of the above features is necessary to make the diagnosis. Clinical finding depend on the type of inflammation. Severity of inflammation. Formation of pericardial fluid. Dry pericarditis. Pericardial effusion without cardiac tamponade. Cardiac tamponade. Pericardial constriction. 1 dry pericarditis. 1 chest pain. Common characteristics 95%. Retrosternal or precordial with radiation to the neck, back, shoulder or arm. Sudden in onset. Special characteristics. More likely to be sharp and pleuritic. Radiation to one or both trapezius muscle ridges suggests a probable pericarditis. Worse with coughing, inspiration, swallowing. Worse by lying supine, relieved by sitting and leaning forward. 2 pericardial friction rub. Is pathognomic for pericarditis. Present in 85% of cases of pericarditis. Scratching or grating sound. Best heard with the diaphragm at the LSP with the patient leaning forward. Pericardial friction rub is audible throughout the respiratory cycle, whereas the pleural rub disappears. Has 3 components, which correspond to atrial systole, ventricular systole, and early diastole. Pericardial rubs start to disappear when effusion develops. EKG. Changes in ECG in patients with acute pericarditis signify inflammation of the epicardium. Widespread upward concave saint segment elevation and PR segment depression. If the ratio of SAINT segment elevation to T wave amplitude in V6 greater than 0.24, acute pericarditis is almost always present. The EKG changes have 4 phases during the course of illness. Sustained arrhythmias are uncommon in acute pericarditis. The presence of atrial or ventricular arrhythmias is suggestive of concomitant myocarditis or an unrelated cardiac disease. Stages of ECG evolution in acute pericarditis. T waves. SAINT segments. PR segments. Stage. Upright. Elevated, diffuse. Depressed. 1. Flat, upright. Isoelectric. 2. Inverted. 3. 4. Acute pericarditis, stage I. Pericarditis stage 2. Pericarditis stage 3. P-wave inversions, differential diagnoses. Clinical. Myocardial infarction. Aortic dissection. Pulmonary embolism. Myocarditis. Pneumothorax. Musculoskeletal. EKG, SAINT ELEV. AMI. Early repolarization. Myocarditis. Hyperkalemia. Ventricular aneurysm. Normal variant. Pericarditis versus early repolarization. Acute pericarditis. Early repolarization. Sex. Either. Usually male. Age. Any. Usually less than 40. PR segment DEV. Common. Uncommon. T waves. Inversion, blunt. Tall, peaked. J SAINT, T ample V6. Greater than 25%. Less than 25%. Tallest precordial R. Usually V5. Usually V4. Early repolarization. Conduction disturbances. Pericarditis. Me. SAINT segment. Diffuse, concave elevation in all leads except AV. Reciprocal changes, R, V1. Height not greater than 5 mm. Localized, convex. Reciprocal changes in infarct. Height may be greater than 5 mm. PR depression. Frequent. Almost never. Q waves. Not usual, unless with infarct. Common with Q wave infarct. T waves. Inverted after J returns to baseline. T inversions and SAINT are not seen simultaneously on the same EKG. Hyperacute T waves is rarely seen. Inverted while SAINT still elevated. T inversions and SAINT can be seen simultaneously on the same EKG. Hyperacute T waves can be seen. Arrhythmias. Rare. Conduction disturbances. Frequent. Anterior myocardial infarction. Pericardial complications of myocardial infarction. Early infarct-associated pericarditis, often termed peri-infarction pericarditis. Pericardial effusion, with or without tamponade. Post-cardiac injury, Dressler's syndrome. Each of these complications is related to infarct size, and has declined in incidence in the revascularization era. Peri-infarction pericarditis, PIP. PIP occurs in approximately 5% of patients treated with fibrinolytic agents versus 20% in those not receiving fibrinolytic therapy. SAINT segments that remain elevated, with persistence of upright T waves, may suggest PIP. Pericardial rubs were heard on day 1 or 2. Echocardiography should be performed to evaluate for the presence of a pericardial effusion. We do not routinely modify antiplatelet therapy. Anticoagulation should be immediately discontinued if a pericardial effusion develops or increases. Treatment with routine anti-inflammatory therapy is generally avoided in patients with PIP because of associated risks, hemorrhagic pericardial effusion, scar thinning and infarct expansion. The use of corticosteroids after myocardial infarction has been associated with a greater incidence of ventricular aneurysm formation. Which of the following ECG abnormalities is not typically associated with acute pericarditis? PR depression, diffuse, concave saint elevation, PR elevation in lead wave, evolution of the Q waves, P wave inversion after segment normalization. Which of the following ECG abnormalities is not typically associated with acute pericarditis? PR depression, diffuse, concave saint elevation, PR elevation in lead wave, evolution of the Q waves, P wave inversion after segment normalization. For echocardiogram normal unless there is an effusion. Presence of effusion supports the diagnosis, but absence does not exclude it. Acute pericarditis is accompanied by pericardial effusion in 60% of cases and tamponade in as many as 15% of cases. The ACC/AHA/ACE all recommend to obtain an echo in any suspected pericardial disease. Laboratory testing CBC, very high WBC, purulent pericarditis. Cardiac enzymes, troponin, CKMB, ESR, CRP, tuberculin skin test, HIV in selected cases, ANR, rheumatoid factor, blood cultures if febrile, viral cultures and antibody testing not indicated. 2. Precardial effusion without tamponade. Symptoms and SINGs, ECG, echo, disappearance of chest pain. Pericardial rub might disappear or it may remain. Heart sound become distant and apical impulse not visible. ECG. Change in T wave not specific for P effusion. T wave flat or T wave inverted. Low voltage, the most common. Electrical alternance. Sinus tachycardia, the combination with low voltage and electrical alternance refers to tamponade. Echo. It is 99% diagnostic to pericardial effusion. Echo showed free area between pericardium and posterior wall of L ventricle. See X-ray in pericardial effusion. Pericardial effusion. Complication of pericarditis. 1. Cardiac tamponade. It is an acute emergency. It develops when intrapericardial pressure equal to the diastolic pressure in the heart. Almost patients with tamponade have one or more of the following physical findings. Hypotension. Sinus tachycardia. Pulse is paradoxus, it is change in systolic blood pressure more than 10 mm of Hg during inspiration. Kussmaul's sign, filling of superior vena cava during inspiration. 2. Constrictive pericarditis. Whole pericardium is thickened and fibrosis so make thick fibrous layer around heart. Can be transient. 10% may have transient within first month, resolves by 3 months. General weakness, wasting, anorexia, dyspnea. The history of previous attack of pericarditis is important. 3. Recurrent pericarditis, 15 to 30%. Less than 6 weeks from initiating event. Most likely an autoimmune etiology. It is reduced in people who initially take colchicine. Jugular venous distension, Kussmaul's sign. Beck's triad in cardiac tamponade. Hypotension. Jugular venous distension, Kussmaul's sign. Distant heart sounds. Electrical alternance in tamponade. RA and RV diastolic collapse. Systole. Late diastole. Early diastole. Doppler echocardiogram in cardiac tamponade. Need for hospitalization. Many physicians tend to admit them, but this may not be necessary. Features of high risk include subacute symptoms, e.g., developing over several days or weeks. High fever, greater than 38 degrees Celsius, 100.4 degrees Fahrenheit, and leukocytosis. Evidence suggesting cardiac tamponade. A large pericardial effusion. Immunosuppressed state. A history of oral anticoagulant therapy. Acute trauma. Failure to respond within 7 days to NSAID therapy, a generous allocation of time. Elevated cardiac troponin, suggestive of myopericarditis. Treatment goals of acute therapy. Relieve pain. Treat the inflammation. Prevent cardiac tamponade and constrictive P. Most viral infections are self-limited. Treat the underlying disease process. Drain purulent effusions. Symptomatic therapy. None of the treatments, unfortunately, have not been proven to prevent the complications. NSAIDs may require weeks to months of treatment with high doses of NSAIDs, and relieved CP in 85 to 90% of patients. If adequate clinical response, continue NSAIDs for 1 week after complete resolution of SX and then taper in 2 to 3 days. 1 aspirin. 650 to 1000 mg 3 times daily. Preferred in patients with ME. 2 ibuprofen. 600 to 800 mg 3 times daily. Above average response rate and has a very good side effect profile. 3 indomethacin. 50 mg 3 times daily. Try to avoid, it can coronary blood flow. Colchicine, Colcres registered. NSAIDs have not been shown to prevent tamponade or long-term complications such as constrictive pericarditis or recurrent pericarditis. A prospective, randomized, open-label design was used. 120 patients with a first episode of acute pericarditis were randomly assigned to conventional treatment with aspirin, group I, or conventional treatment plus colchicine 1.0 to 2.0 mg for the first day and then 0.5 to 1.0 mg/d for 3 months, group 2. Colchicine significantly reduced the recurrence rate, 10.7% versus 32.3%, p equals 0.004, and presence of symptoms at 72 hours, 11.7% versus 36.7%, p equals 0.003. Based upon this, addition of it to the RX regimen for an initial episode of acute pericarditis is an option for physicians. Treatment of PIP. ACC/AHA guidelines recommend aspirin as the preferred agent for the treatment of PIP, noting that doses as high as 650 to 1000 mg 3 times daily may be needed. I. Colchicine, half a milligram every 12 hours, Corticosteroids or non-steroidal anti-inflammatory agents, IIB. Ibuprofen, 3 harm. Steroid-specific conditions that will benefit. In patients refractory to NSAIDs and colchicine or cannot be tolerated. Steroid therapy with initial episode is more likely associated with recurrent episodes. Evidence available argues against the routine administration of corticosteroids during a first episode of acute pericarditis. Specific conditions that will benefit. Acute pericarditis due to connective tissue diseases. Autoimmune pericarditis. Uremic pericarditis.